The Acumed fibular rod system is an innovative solution to address distal fibular fractures. By incorporating straightforward targeting with a minimally invasive surgical approach, the fibular rod provides benefits to patients with comorbidities such as diabetes, soft tissue, and/or vascular issues. The fibular rod is inserted through a small incision, which may aid in reducing deep wound sepsis and other surgical complications. The following surgical technique is the suggested method for implanting the fibular rod. The patient should be placed supine with a roll under the ipsilateral buttock. The fibula should be aligned and the ankle joint reduced by ligamentotaxis and manipulation before commencing surgery. Make a 15 mm longitudinal incision located 10 mm below the distal tip of the fibula. Establish the entry point on the distal tip of the fibula with a 1.6 mm guide wire. Confirm wire position with thoracoscopy in both the anterior and lateral planes. Once the guide wire is placed, carefully drill the distal 40 mm of the fibula with a cannulated 6.1 mm. The drill is at proper depth when the drill flutes are buried. Remove the drill and guide wire. The diaphyseal canal is then prepared by sequentially reaming with the hand reamers. Starting with a 3.1 mm reamer, ream the canal to the nearest indicated depth mark, which corresponds to implant lengths of 110, 145, or 180 mm. Follow this step with a 3.7 mm reamer for patients with larger canals. The reamer should always be used to ensure that the rod will pass through the canal without becoming impacted upon insertion. Rod diameter is determined by the last diameter of the reamer used. Two proximal diameters are available, 3 and 3.6 mm. The 3 mm rod is paired with a 3.1 mm reamer. The 3.6 mm rod is paired with a 3.7 mm reamer. Rod length is determined by the depth of reaming, as indicated by the marking on the reamer shaft. Attach the base plate to the unmarked side of the black targeting guide to ensure proper orientation. Secure these two components with a rosette knob. Next, assemble the selected fibular rod to the base plate barrel by aligning the barrel key to the rod keyway. Laser marks on both the barrel and rod should be aligned. Secure the fibular rod to the base plate with the locking bolt, using the finger wrench to tighten. When properly assembled, the fibular rod will curve towards the targeting guide. The AP guide can be mounted to the base plate at this time. If a patient's soft tissues are swollen, the AP guide can be mounted just prior to AP screw insertion. The guide should be mounted on the anterior side of the base plate, as AP screws should always be inserted from the anterior direction. Carefully advance the fibular rod into the canal of the fibula. To check for proper insertion depth, place the 1.6 mm guide wire through the targeting guide, which will align with the distal end of the rod. Confirm depth under fluoroscopy. The fibular rod should be buried just below the surface of the cortex. The first screw to be implanted should be an AP screw. But before this is done, the rod must be in proper axial alignment for subsequent syndesmosis screw placement. Optimal placement of the syndesmosis screw is achieved when the targeting guide is externally rotated 10 to 15 degrees. If there is significant external rotation of the distal fragment, additional rotation may be required such that the reduced position of the fragment is aligned for the optimal placement of the syndesmosis screw. Mark the skin through the AP guide and make a small stab incision to access the bone. Insert the 3.5 mm cannula and the 3.5 mm drill guide into the AP guide. Drill to, but not through, the second cortex and make a measurement reading from the drill. Insert a screw through the cannula that reaches to but does not penetrate the posterior cortex. This will help to avoid perineal tendon irritation. 1 or 2 screws are inserted according to surgeon preference. Remove the AP guide. The distal fragment is now secured to the fibular rod, which is attached to the targeting guide assembly. Use the targeting guide assembly to reduce the ankle mortise anatomically through gentle, controlled movements. Confirm adequate reduction with fluoroscopy. While maintaining manual reduction, mark the skin through the targeting guide and make a small incision to access the bone. Insert the cannula and drill guide through the targeting guide. If proper posterior rotation was previously applied, the cannula should have a slight posterior to anterior orientation. Drill at least 3 cortices and make a measurement reading from the drill. Insert an appropriate length screw through the cannula. This step is recommended regardless of whether or not there is mechanical instability of the syndesmosis. 1 or 2 screws can now be inserted according to surgeon preference. The fibular rod is now locked, preventing longitudinal or rotational displacement, and the lateral buttress of the mortise is now anatomically restored and stabilized, assuring the long-term alignment during healing. Loosen the locking bolt with a finger wrench and remove the targeting guide assembly. The skin can be closed with steri-strips or sutures according to the surgeon's preference. For specific questions not addressed here, please contact your local Acumed sales representative or Acumed directly, either at 888-627-9957 or on the web at www.acumed.net.